A 45-year-old patient presents with a fever, dry cough, and pleuritic chest pain. I am showing you a frontal chest radiograph and an axial chest computed tomography scan. Describe the findings.
The chest radiograph demonstrates multiple poorly defined pulmonary opacities bilaterally. The axial chest computed tomography scan demonstrates multiple nodular opacities, with the most prominent nodule in an upper lobe surrounded by a ring of ground glass attenuation, representing the classic computed tomography halo sign. There is also a peripheral distribution to these lesions.
Based on these imaging findings, what is your primary concern and the differential diagnosis?
The primary concern is an angioinvasive infection, most commonly invasive pulmonary aspergillosis. The differential diagnosis for the computed tomography halo sign includes other angioinvasive fungal infections like mucormycosis, GPA, or hemorrhagic metastases.
If I tell you the patient is currently undergoing induction chemotherapy for acute myeloid leukemia and is profoundly neutropenic, how does this clinical history affect your diagnosis?
In the clinical setting of profound neutropenia, the presence of the computed tomography halo sign is highly suggestive of early invasive pulmonary aspergillosis, which is a life-threatening opportunistic infection.
What does the ground glass attenuation surrounding the central nodule represent pathologically?
Pathologically, the ground glass halo represents localized alveolar hemorrhage. This surrounds a central area of pulmonary infarction necrosis caused by angioinvasive fungal hyphae, occluding the pulmonary arteries.
Is the computed tomography halo sign typically seen early or late in the course of invasive aspergillosis?
The computed tomography halo sign is an early finding, typically observed during the first 10 days of infection when the patient is profoundly neutropenic.
Describe the late radiological sign of this infection and its appearance.
The late sign is the air crescent sign, which appears as a crescentic pocket of air surrounding a central, dense nodular sequestrum of necrotic lung tissue.
Explain the relationship of the air crescent sign to the patient's immune status.
The air crescent sign occurs during neutrophil recovery. As the bone marrow recovers and the absolute neutrophil count rises, the neutrophils migrate to the periphery of the infarcted tissue, sloughing off the necrotic sequestrum.
What is the clinical prognostic significance of the air crescent sign?
The air crescent sign is generally a good prognostic indicator because it signifies bone marrow recovery and resolution of the host's profound neutropenia.
What is the critical safety warning associated with the tissue sloughing phase?
During neutrophil recovery and tissue sloughing, there is a high risk of erosion into adjacent major pulmonary blood vessels, which can cause sudden, catastrophic, and life-threatening massive hemoptysis.
What are the immediate clinical management steps you would recommend?
I would recommend immediate initiation of empiric voriconazole or isavuconazole therapy without waiting for culture results. I would also suggest checking serum galactomannan levels, performing a diagnostic bronchoscopy if safe, and referring urgently to infectious diseases.